Welcome to Chapter 2, where we'll focus on the anatomy of the extraocular muscles within pediatric ophthalmology and strabismus. This chapter lays the groundwork for everything that follows, because understanding how these muscles are organized, where they originate, and how they act is essential for making sense of eye movements and ocular misalignment in children. As we move through this material, think of it as building a structural map, one that will help explain clinical patterns you see in the exam room and, later on, the logic behind strabismus surgery. Before we dive into individual muscles, it's worth framing a few key ideas that will keep coming up throughout this chapter. The oblique muscles are primarily responsible for vertical eye movements, with the superior oblique acting to depress the eye and the inferior oblique acting to elevate it. A central concept here is the trochlea, which functions like a pulley and redirects the force of the superior oblique, fundamentally changing the direction of its pull. Beyond the trochlea, it's important to recognize that all of the rectus and oblique muscles interact with pulley-like connective tissue structures within the orbit, rather than acting as simple straight-line tethers. Finally, from a surgical standpoint, the anterior ciliary vessels deserve attention. These vessels can be disrupted during strabismus surgery, and operating on 3 or more rectus muscles increases the risk of anterior segment ischemia, an anatomic detail with real clinical consequences. At a structural level, there are 7 extraocular muscles that control eye position and eyelid elevation. These include the 4 rectus muscles, the 2 oblique muscles, and the levator palpebrae superioris. Together, they form an organized system that surrounds the globe and determines how the eye moves within the orbit. Their spatial relationships are best appreciated using standard anterior orbital diagrams like the one shown here. Viewing the orbit from the front allows you to see how the rectus muscles insert around the globe, how the obliques take a more complex course, and how the levator palpebrae superioris sits superiorly to elevate the upper eyelid. Keeping this anatomic layout in mind will make it much easier to understand muscle actions, patterns of strabismus, and the surgical approaches discussed later in the chapter. Now we can get more specific about the rectus muscles by focusing on where they originate and how they course through the orbit. The horizontal and vertical rectus muscles all arise from the annulus of Zinn at the orbital apex, then travel forward toward their insertions on the globe. As they approach the sclera, these muscles become thin and ribbon-like. Although we often refer to their insertions as tendons, the insertion zone actually contains striated muscle fibers intermixed with true tendinous tissue. This matters surgically because the sclera is thinnest just posterior to the 4 rectus insertions, which increases the risk of scleral perforation, particularly during small rectus recessions. In terms of their individual courses, the medial rectus runs straight along the medial orbital wall, while the lateral rectus follows the lateral orbital wall. The superior rectus travels anteriorly, upward over the globe and laterally, forming an angle of about 23 degrees with the visual axis in primary position. The inferior rectus takes a similar but mirrored path, running anteriorly, downward, and laterally along the orbital floor, and it also makes an angle of roughly 23 degrees with the visual axis in primary position. Now let's turn to the superior oblique and walk through its origin, course, and function, because this muscle behaves very differently from the rectus muscles. The superior oblique originates from the orbital apex, just above the annulus of Zinn, and then courses anteriorly and upward along the superomedial orbital wall. As it travels forward, the muscle becomes tendinous before reaching the trochlea, which is a cartilaginous pulley located on the superior nasal frontal bone. This pulley is critical because the tendon-trochlea complex redirects the force of the muscle inferiorly, posteriorly, and laterally. As a result of this redirection, the superior oblique forms an angle of about 51 degrees with the visual axis in primary position. After passing through the trochlea, the tendon emerges roughly 2 mm nasal and 5 mm posterior to the superior rectus insertion. It then passes beneath the superior rectus muscle and inserts posterior to the equator in the superotemporal quadrant of the globe. This posterior insertion is what gives the superior oblique its vertical action. By pulling on the posterior globe, the muscle depresses the eye rather than elevating it, despite its superior location. In contrast to the superior oblique, the inferior oblique has a very different origin and surgical profile. It originates inferonasally from the maxillary bone, just posterior to the orbital rim and lateral to the lacrimal fossa. From there, it courses laterally, superiorly, and posteriorly, traveling beneath the inferior rectus muscle. The inferior oblique then inserts under the lateral rectus on the posterolateral aspect of the globe, near the macula. Like the superior oblique, it forms an angle of about 51 degrees with the visual axis in primary position. Because its insertion is posterior to the equator, its primary vertical action is elevation, achieved by pulling the posterior globe downward. An important anatomical variation to keep in mind is that most inferior oblique muscles have a single muscle belly, but about 10% have two parallel bellies, and rarely there may be three. This variation has direct surgical implications. During inferior oblique surgery, careful identification of all muscle bellies is essential because missing an accessory belly can lead to an inadequate surgical effect and the need for additional intervention. This diagram pulls together several of the anatomic concepts we've been building toward by showing the extraocular muscles in primary position, viewed from above. What's especially important here is the relationship between the visual axis and the muscle planes. You can see that the superior and inferior rectus muscles do not act straight along the visual axis. Instead, each forms an angle of about 23 degrees with it, which explains why these muscles have combined vertical and torsional effects, rather than producing pure elevation or depression. The oblique muscles contrast with this arrangement. Their courses and insertions place them in a different plane entirely, allowing them to exert stronger torsional and vertical influences depending on eye position. This figure also highlights how the inferior oblique's origin and insertion are not fully visible from the superior view, reinforcing how different its anatomy is compared with the rectus muscles. Keeping these angular relationships in mind is critical because they form the mechanical basis for understanding ocular motility patterns and for predicting muscle actions during clinical testing and surgery. The final muscle to consider in this anatomic overview is the levator palpebrae superioris, which is responsible for elevation of the upper eyelid. It arises from the orbital apex at the lesser wing of the sphenoid bone, just superior to the annulus of Zinn. At its origin, it has close anatomic relationships, blending with the superior rectus inferiorly and the superior oblique medially. From there, the levator courses anteriorly, lying just above the superior rectus muscle. Their fascial sheaths are interconnected, which explains why pathology or surgery involving one structure can affect the other. As it approaches the anterior orbit, the levator transitions into an aponeurosis in the region of the superior fornix. Distally, the levator has two insertions. One is a cutaneous insertion that contributes to the upper eyelid crease, and the other is a tarsal insertion that directly elevates the eyelid. While this overview covers the key concepts relevant to strabismus and pediatric ophthalmology, more detailed descriptions of levator anatomy are typically explored in greater depth within oculofacial and orbital surgery references. This slide introduces an important spatial pattern in how the rectus muscles insert onto the globe. If you move around the limbus from the medial rectus to the inferior rectus, then to the lateral rectus, and finally to the superior rectus, each insertion lies progressively farther posterior to the limbus. When you connect these insertion points, they form a gentle curve known as the spiral of Tillot. This relationship isn't just an anatomic curiosity, it has practical implications in surgery and localization. The predictable progression helps orient you intraoperatively and explains why the rectus insertions are not arranged in a perfect circle. An additional detail to note is that for both vertical rectus muscles, the temporal edges of their insertions sit farther posterior than their nasal edges. That asymmetry contributes to their torsional effects and is another example of how subtle anatomy translates into functional eye movements. To round out the anatomy of the extraocular muscles, it's essential to understand their innervation, because nerve involvement often explains clinical patterns more clearly than muscle anatomy alone. Cranial nerve 6, the abducens nerve, innervates the lateral rectus muscle, making it solely responsible for abduction of the eye. Cranial nerve 4, the trochlear nerve, innervates the superior oblique. This unique pairing is worth remembering, since the superior oblique is the only extraocular muscle supplied by cranial nerve 4. All of the remaining extraocular muscles are innervated by cranial nerve 3, the oculomotor nerve. This includes the levator palpebrae superioris, the superior rectus, medial rectus, inferior rectus, and inferior oblique. Cranial nerve 3 divides into an upper and a lower division. The upper division supplies the levator palpebrae superioris and the superior rectus, while the lower division innervates the medial rectus, inferior rectus, and inferior oblique. In addition to motor innervation, cranial nerve 3 also carries parasympathetic fibers. These fibers travel with the lower division and ultimately supply the sphincter pupillae for pupil constriction and the ciliary muscle for accommodation. This dual motor and parasympathetic role is why third nerve pathology can produce a combination of eye movement abnormalities, ptosis, and pupillary involvement. This slide highlights where the motor nerves actually enter the extraocular muscles, which is an important detail for both understanding function and avoiding injury during surgery. The inferior oblique is a key exception to the general pattern. Its nerve enters the lateral portion of the muscle, crossing over the inferior rectus to reach it, rather than approaching from the orbital apex side. For most of the rectus muscles, as well as the superior oblique, the motor nerves enter the muscle belly at roughly 1/3 of the distance from the origin to the insertion. In the case of the superior oblique, the nerve entry is closely associated with the trochlea rather than the insertion site. These predictable entry points help explain patterns of selective muscle weakness in nerve palsies and also serve as important landmarks during strabismus surgery to minimize the risk of denervation. To close out this section, it's important to connect nerve anatomy directly to surgical risk. Inferior oblique surgery carries a particular concern because of the proximity of the inferior oblique nerve to nearby parasympathetic fibers. Injury in this area can affect those fibers and may result in an enlarged pupil or a tonic pupil postoperatively, even when the muscle surgery itself appears uncomplicated. In contrast, direct injury to rectus muscle nerves is less common. When it does occur, it's usually related to excessive posterior dissection. Passing an instrument more than about 26 millimeters posterior to a rectus insertion places the motor nerve at risk. This anatomic limit is a useful mental boundary during surgery and reinforces why controlled anterior dissection is critical when working on the rectus muscles. This slide shifts our focus from individual muscles to the broader framework that supports them within the orbit. The globe isn't freely floating in space. It's suspended by a musculo-fibroelastic system that stabilizes eye position while still allowing smooth, coordinated movement. This system provides structural support for the extraocular muscles as they course through the orbit and helps maintain consistent muscle paths during eye movements. At the same time, it organizes the orbital contents by creating compartments for the orbital fat pads. Rather than being a single undifferentiated mass, orbital fat is divided into regions by these fascial structures, which helps cushion the globe and accommodate movement without interference. Understanding these orbital and fascial relationships is important because they influence both normal motility and surgical planes. When these supporting structures are altered by disease, trauma, or surgery, the effects extend beyond a single muscle and can change how the entire orbital system functions. This slide emphasizes that strabismus isn't always a problem of muscle strength or innervation alone. It can also arise from abnormalities in the connective tissue framework of the orbit. When the orbital fascia or related connective tissues are disrupted, normal muscle paths and force vectors can be altered, leading to misalignment even if the muscles themselves are intact. A common example is entrapment of connective tissue in orbital blowout fractures. In this setting, restriction of normal tissue movement can tether an extraorbital muscle or its surrounding fascia, producing a mechanical strabismus. Another important example is extraorbital muscle pulley heterotopy, where abnormal positioning of the pulley system changes the effective direction of muscle pull. These conditions highlight why understanding orbital fascia is essential for both diagnosis and surgical planning in complex strabismus cases. The slide brings together the relationship between orbital fat and Tenon's capsule, which is central to how the globe is supported and protected within the orbit. The eye is cushioned by abundant orbital fat, which acts as both a protective buffer and a space-filling structure that allows smooth ocular movement. Orbital fat is arranged in a structured way, rather than randomly. Fat that lies outside the muscle cone extends anteriorly, but typically ends about 10 millimeters from the limbus. At the same time, fat is also present within the muscle cone, surrounding the optic nerve and deep orbital structures. These two fat compartments are separated and organized by the extraocular muscles and their associated septa. Tenon's capsule plays a critical role here by separating the orbital fat from the sclera. It forms a smooth, fibrous envelope around the globe, allowing the eye to rotate freely without direct contact with surrounding fat. This anatomic barrier is especially important surgically because violating Tenon's capsule changes the operative plane and can expose orbital fat, altering both surgical visibility and postoperative behavior of the tissues. This slide focuses on why Tenon's capsule is such an important surgical boundary during strabismus procedures. During surgery, it's critical to avoid violating Tenon's capsule more than about 10 millimeters posterior to the limbus. Staying anterior to this plane helps maintain the normal separation between the globe and the orbital fat. If Tenon's capsule is breached posteriorly, orbital fat can prolapse into the surgical field. That fat exposure isn't just a nuisance. It can lead to the formation of restrictive adhesions during healing. These adhesions may involve the sclera, extraocular muscles, the intermuscular septum, or even the conjunctiva itself. When adhesions form across these structures, they can mechanically limit ocular motility and create a restrictive strabismus that's often more difficult to correct than the original misalignment. This is why careful respect for Tenon's capsule and deliberate dissection planes are essential principles in strabismus surgery.
This slide defines the muscle cone, which is a key anatomic concept for orienting yourself within the orbit. The muscle cone is located posterior to the equator of the globe and represents the space created by the extraocular muscles as they converge toward the orbital apex. It's formed by the extraocular muscles themselves, along with their fascial sheaths and the intermuscular septum. Posteriorly, the intermuscular septum plays an important role by dividing the orbital fat into two distinct compartments. Fat that lies within the boundaries of the cone is referred to as intraconal fat, while fat outside those boundaries is considered extraconal. Understanding the distinction between intraconal and extraconal spaces is critical for both imaging interpretation and surgical planning. Many orbital pathologies and surgical approaches are described in terms of their relationship to the muscle cone, making this a foundational spatial concept in orbital anatomy.
This slide connects the anatomy of the muscle cone to practical considerations during anesthesia and surgery. Cranial nerve 4 runs outside the muscle cone, which is why it's usually spared during a standard retrobulbar block. Because it lies extraconally, the anesthetic often doesn't reliably affect the superior oblique. That said, a retrobulbar needle can still physically reach any of the extraocular muscles, regardless of their position relative to the cone. If the needle contacts a muscle directly, local anesthetic injection can injure the muscle itself, leading to postoperative motility disturbances. The key takeaway here is that while the muscle cone helps predict patterns of nerve blockade, it doesn't eliminate risk. Needle position and depth still matter, and unintended contact with extraocular muscles remains a potential source of iatrogenic strabismus. This slide focuses on the muscle capsule, which plays a key role in how the rectus muscles move smoothly over the surface of the globe. Each rectus muscle is surrounded by a fascial capsule that extends continuously from its origin all the way to its insertion. Posteriorly, this capsule is relatively thin. As the muscle approaches the equator of the globe, the capsule thickens as it passes through the Tenon sleeve in the region of the extraocular muscle pulley. From there, it continues anteriorly with the muscle towards its insertion. Once you move anterior to the equator, there is very little true fascia. Instead, the muscle is attached to the globe primarily by connective tissue footplates rather than a robust fascial layer. The surface of the capsule itself is smooth and avascular, which allows the muscles to glide over the globe with minimal friction. This low-friction interface is essential for normal ocular motility and is another reason why disruption of these tissues can lead to restrictive eye movement. This slide ties the anatomy of the muscle capsule directly to surgical technique and outcomes. Preserving the integrity of the capsule during strabismus surgery helps reduce bleeding and minimizes postoperative adhesion formation, both of which contribute to smoother healing and more predictable motility. When suturing within the capsule, it's critical that the suture actually captures muscle fibers themselves, not just the surrounding fascial tissue. If only the capsule is secured to the sclera, the muscle can retract posteriorly within the capsule. This results in a slipped muscle, which can present as an unexpected postoperative deviation and often requires reoperation. The practical message here is that while the capsule provides a useful surgical plane, it can also be misleading. Clear identification of true muscle fibers is essential to ensure durable attachment and effective surgical correction. This slide brings together Tenon's capsule and the intermuscular septum as a unified fascial system that enables controlled globe movement within the orbit. Tenon's capsule is the principal orbital fascia, forming the envelope around the globe. Posteriorly, it fuses with the optic nerve sheath, and anteriorly, it blends with the intermuscular septum about 3 millimeters from the limbus. In the posterior orbit, Tenon's capsule is thin and flexible. This allows free movement of the optic nerve, ciliary nerves, and blood vessels, while still separating intraconal fat from the sclera. As you move to the level of the equator and just posterior to it, Tenon's becomes thicker and tougher, creating a fibroelastic support system that helps suspend the globe through its connections to the periorbita. The relationship between Tenon's and the extraocular muscles is also position-dependent. The global layer of the rectus muscles penetrates this fibroelastic tissue about 10 millimeters posterior to their insertions, whereas the oblique muscles penetrate anterior to the equator. From there, Tenon's extends forward over all 6 extraocular muscles, separating them from orbital fat and other structures outside the muscle cone. This layered organization explains how the eye can move freely while remaining stably supported within the orbit. This figure gives a visual sense of how Tenon's capsule envelops the globe and interfaces with the extraocular muscles. In the top image, you're seeing the globe after enucleation, which makes the anterior and posterior openings of the Tenon's capsule easier to appreciate. The rectus muscles and oblique tendons pass through this fascial envelope, highlighting how Tenon's forms a continuous sleeve around the eye, rather than a flat layer. In the lower image, the Tenon space is demonstrated by distending it with injected dye. This helps illustrate that Tenon's capsule creates a true potential space around the globe, allowing the eye to move smoothly within its fascial envelope. You can also see how the sheaths of the superior and inferior rectus muscles blend with Tenon's as they course forward, reinforcing the idea that muscle movement and globe movement are mechanically linked through this shared fascial system. Taken together, these images reinforce why respecting Tenon's capsule matters surgically. It's not just a passive covering, it's an active, continuous structure that permits low-friction motion of the globe while maintaining organized relationships between the eye, the muscles, and the surrounding orbital tissues. This slide focuses on how Tenon's capsule and the intermuscular septum guide surgical decision-making. The intermuscular septum is a particularly important landmark when you're trying to locate a lost muscle during surgery or after trauma, because it helps orient you to where the rectus muscles should lie relative to one another. In routine surgery, extensive dissection of the intermuscular septum isn't necessary for a resection. However, during a resection, freeing the septum can be helpful to avoid advancing excess connective tissue along with the muscle, which could otherwise affect postoperative alignment. Finally, it's important to recognize how these tissues change with age. Tenon's capsule and the intermuscular septum become thinner over time, which means less dissection is typically required in adult strabismus surgery compared with pediatric cases. This age-related difference helps explain why surgical planes often feel tighter and more fibrous in children than in adults. This slide introduces the pulley system, which fundamentally changes how we think about extraocular muscle mechanics. The superior oblique is unique in that it uses a true anatomic pulley at the trochlea. In contrast, all of the other extraocular muscles pass through fibroelastic, pulley-like connective tissue sleeves rather than fixed bony pulleys. These pulley tissues are not passive. They contain collagen, elastin, and smooth muscle, and they're located near the equator of the globe where the muscles pass through Tenon's capsule. Imaging studies, particularly MRI, have shown that these pulleys can behave mechanically like functional muscle origins, effectively redefining where muscle force is applied. Functionally, the pulley system stabilizes the posterior paths of the extraocular muscles. By doing this, it prevents unwanted side slip or perpendicular deviation from the intended muscle axis, allowing eye movements to remain precise and coordinated. The muscle sheaths themselves send multiple extensions to the orbit, helping support both the muscles and the globe. The inferior oblique fits into this system in a distinctive way. It originates near the orbital rim and enters its pulley inferior to the inferior rectus. The pulleys of the inferior oblique and inferior rectus then fuse to form the Lockwood ligament. Along the lateral border of the inferior rectus, this ligament contains a dense neurofibrovascular bundle. That bundle includes the inferior oblique motor nerve and functions as the effective or functional origin of the inferior oblique muscle. Think of the inferior oblique muscle like a rope that doesn't start pulling exactly where it's attached to the bone. Even though the inferior oblique technically starts near the front edge of the orbit, that's not where it really acts from. As it travels backward, it passes through a soft pulley system underneath the inferior rectus muscle. This pulley changes the direction of the pull, kind of like when you loop a rope over the edge of a table to lift something. That pulley for the inferior oblique is connected to the pulley of the inferior rectus, and together they form a supportive band called the Lockwood ligament. Inside that band is a tight bundle that includes the nerve that powers the inferior oblique. Because the muscle changes direction there and the nerve enters at that point, this pulley area acts like the real starting point of the muscle. So, even though the inferior oblique begins near the front of the orbit, its pulley is what actually sets the direction and strength of its movement. That's why we say the pulley acts as the functional origin of the inferior oblique. It's where the muscle really starts doing its job. This slide explains how the pulley system works together with the layered structure of the extraocular muscles. Most rectus muscles, except for the levator, are built with two distinct layers. The orbital layer sits closer to the orbit and interfaces directly with the connective tissue pulleys, while the global layer extends forward and inserts onto the sclera, where it actually moves the globe. This layer design has led to what's called the active pulley hypothesis. The idea is that when the orbital layer contracts, it may be able to shift the position of the pulley itself, subtly changing the direction of muscle pull. Whether this process is under true independent neural control remains controversial, but the concept helps explain how eye movements can be so finely tuned. In normal anatomy, pulleys don't move very much. Even during large eye movements, their position shifts only slightly within the coronal plane. However, high-resolution MRI studies show that pulleys sit very close to the center of the globe. Because of that proximity, even small changes in pulley position can significantly alter the direction of force applied by a muscle. This helps explain how relatively subtle anatomic variations in the pulley system can produce meaningful changes in ocular alignment and motility. This slide explains how problems with the pulley system can create specific strabismus patterns, even when the muscles themselves are normal. When rectus pulleys are malpositioned, a situation referred to as pulley heterotopy, the direction of muscle pull changes. Because the force vector is altered, the eyes may not move together in all directions, producing incomitant strabismus and characteristic A or V pattern deviations. These patterns can be misleading clinically. Because redirected rectus muscle forces can create vertical or torsional effects, pulley heterotopy may mimic oblique muscle dysfunction, even though the oblique muscles are functioning normally. In other words, what looks like an oblique problem may actually be a rectus pulley problem. Pulley position can be altered by the surrounding orbital anatomy. Bony abnormalities, such as those seen in craniosynostosis, can distort the normal pathways of the pulleys and redirect muscle forces. Pulley heterotopy can also be acquired later in life. With age, connective tissue becomes more lax, allowing pulleys to sag or shift. This mechanism underlies conditions like sagging eye syndrome and adult-onset distance esotropia, where the strabismus is driven by connective tissue changes rather than primary muscle weakness or nerve dysfunction. This slide highlights how the rectus muscles are mechanically linked to the eyelids through their connective tissue attachments, which explains why strabismus surgery can change eyelid position, even when the eyelids themselves aren't directly operated on. The inferior rectus has a particularly strong connection to the lower eyelid through fascial extensions from its muscle sheath. Because of that tight linkage, surgery on the inferior rectus predictably affects lower eyelid position. When the inferior rectus is resected, the lower lid is pulled upward, which narrows the palpebral fissure. In contrast, recessing the inferior rectus allows the lower lid to drop back, leading to lower lid retraction and a widened fissure. The superior rectus behaves a bit differently. Its connection to the eyelid is looser and mediated through the levator complex rather than a direct, firm attachment. When the superior rectus is resected, it can pull the upper eyelid downward, narrowing the palpebral fissure. However, a moderate superior rectus recession usually does not cause upper lid retraction, which is an important clinical distinction. Finally, in cases of hypotropia, the eyelid can appear droopy even when the levator itself is functioning normally. In this situation, the upper eyelid follows the downward position of the globe driven by the superior rectus, creating the appearance of ptosis. This is referred to as pseudotosis and resolves when ocular alignment is corrected, rather than with eyelid surgery. This slide is about how some eye muscles are physically tied to each other and why that matters during surgery. The lateral rectus isn't completely independent. Near its insertion, it's connected to the inferior oblique by a small band of connective tissue, sometimes described as a frenulum. The superior rectus has a similar setup, with a connective tissue link to the superior oblique tendon. These connections act like safety tethers between the rectus and oblique muscles. During normal eye movements, these linkages help coordinate motion and keep forces balanced. Surgically, they play an important protective role. When a surgeon recesses or resects the lateral rectus or superior rectus, these connective tissue bands help prevent the nearby oblique muscle from being unintentionally pulled forward or displaced. If those attachments are cut or disrupted, problems can arise. For example, during lateral rectus surgery, severing the connection to the inferior oblique can allow the inferior oblique to advance unintentionally. That can change its effective action and lead to unexpected vertical or torsional deviations postoperatively. The key takeaway is that rectus muscle surgery doesn't happen in isolation. These rectus-oblique connective tissue relationships help maintain normal muscle balance, and preserving them is important to avoid creating new motility problems while trying to fix another one. The medial rectus has a unique anatomic relationship compared with the other rectus muscles. It is the only rectus muscle that does not have an adjacent oblique muscle running tangentially alongside it. This makes medial rectus surgery relatively straightforward from an anatomic standpoint, since there are fewer neighboring structures to manage. However, this simplicity also creates a limitation. If the medial rectus becomes lost or disinserted during surgery, there is no nearby oblique muscle to serve as a natural landmark for relocation. As a result, although medial rectus surgery is generally simpler to perform, recovery of a lost medial rectus can be more challenging due to the lack of adjacent anatomic reference points. This slide reviews the arterial supply to the extraocular muscles. The primary blood supply comes from the ophthalmic artery, which gives rise to distinct muscular branches. The lateral muscular branch supplies the lateral rectus, the superior rectus, and the superior oblique. In contrast, the medial muscular branch is typically larger and supplies the inferior rectus, the medial rectus, and the inferior oblique. In addition to these primary branches, there are supplemental contributions. The lacrimal artery provides partial blood supply to the lateral rectus, while the infraorbital artery contributes to the inferior oblique and inferior rectus. These arterial branches also supply the levator palpebrae superioris, reflecting the close vascular relationship between eyelid elevation and ocular motility. Overall, this overlapping vascular supply helps explain why isolated ischemia of a single extraocular muscle is relatively uncommon, even in the setting of localized vascular compromise. This slide focuses on the anterior ciliary circulation and how it relates to the rectus muscles. The muscular branches of the ophthalmic artery give rise to the anterior ciliary arteries, which travel forward alongside the rectus muscles. Each rectus muscle typically contributes between 1 and 4 anterior ciliary arteries. As these vessels course anteriorly, they traverse the episclera and play a major role in supplying the anterior segment of the eye. They provide nearly all of the blood supply to the temporal half of the anterior segment and the majority of the nasal half. Additional blood flow to the anterior segment comes from perilimbal anastomoses and conjunctival vessels, which help reinforce this circulation and provide redundancy. Traditionally, it was thought that the lateral rectus contributed fewer anterior ciliary arteries than the other rectus muscles. However, More recent anatomic studies challenge this idea and suggest that the lateral rectus has a ciliary contribution similar to that of the other rectus muscles. This slide highlights an important surgical consideration related to blood supply. Each rectus muscle contributes anterior ciliary arteries to the anterior segment, so operating on multiple rectus muscles at the same time can significantly reduce anterior segment perfusion. When surgery involves 3 rectus muscles simultaneously, there is an increased risk of anterior segment ischemia. This risk is particularly relevant in older patients and in those with underlying vasculopathic conditions, such as diabetes, hypertension, or other causes of compromised microvascular circulation. Because of this, surgical planning often aims to limit the number of rectus muscles operated on in a single setting, stage procedures when necessary, and preserve as much anterior ciliary circulation as possible. Awareness of this risk is critical to preventing serious postoperative complications involving the cornea, iris, and ciliary body. This slide reviews the venous drainage of the extraocular muscles and nearby ocular structures. Venous outflow generally parallels the arterial supply and ultimately drains into the superior and inferior orbital veins. Most eyes have 4 or more vortex veins, which are typically located posterior to the globe's equator. These veins are responsible for draining the choroid and are important landmarks during posterior dissection. Common locations for vortex veins include areas near the nasal and temporal margins of the superior and inferior rectus muscles. 2 especially consistent sites are the inferotemporal quadrant, usually posterior to the inferior oblique, and the supratemporal quadrant, posterior to the superior oblique tendon. Recognizing these typical locations is important during strabismus and orbital surgery to avoid inadvertent injury and bleeding. This slide focuses on surgical considerations related to the vortex veins. During inferior rectus or superior rectus recession or resection, there is a real risk of accidental injury to a vortex vein, particularly because these veins lie posterior to the muscle insertions and may not be immediately visible during dissection. There is also a risk of vortex vein injury when exposing the superior oblique tendon, especially in the supratemporal quadrant, where a vortex vein is commonly located just posterior to the tendon. Injury to a vortex vein can result in significant bleeding, and if the surrounding connective tissue attachments are disrupted, it may also lead to unintended weakening of the inferior oblique. If a vortex vein is injured, hemostasis can usually be achieved with careful cautery or placement of an absorbable hemostatic sponge. Awareness of typical vortex vein locations and deliberate posterior dissection are key to minimizing these complications.
This slide highlights what makes extraocular muscle fibers functionally unique. These muscles are capable of producing the fastest movements in the human body, which are saccades, while also sustaining highly controlled, steady actions like fixation and vergence over long periods of time. Although extraocular muscles are striated and voluntary, like other skeletal muscles, they are structurally and functionally distinct. One of the most important differences is their extremely high innervation ratio, with roughly 1 motor neuron supplying only 3 to 5 muscle fibers. This is dramatically higher than typical skeletal muscle and can be up to 10 times greater. That dense innervation allows for exceptionally fine motor control. It supports everything from simple reflexive eye movements to complex, coordinated vergence responses, enabling precise alignment and stability of the eyes across a wide range of visual tasks.
This slide reviews singly innervated fibers, which are the fast-twitch fibers of the extraocular muscles. They make up the majority of the muscle, accounting for about 90% of fibers in the global layer and roughly 80% in the orbital layer. In the global layer, these fibers are classified as red, intermediate, or white based on mitochondrial content, with red fibers being the most fatigue-resistant and white fibers the least. In the orbital layer, singly innervated fibers have high mitochondrial density and contribute importantly to sustained eye position in both primary and deviated gaze. Clinically, these fibers are the most susceptible to denervation, including motor nerve or in-plate injury and the effects of botulinum toxin. This slide introduces multiple innervated fibers, which are found in both the orbital and global layers of the extraocular muscles, but notably are not present in the levator palpebrae. These fibers are thought to play a key role in fine fixation control and smooth graded eye movements rather than rapid saccades. They are especially important for virgins, helping the eyes make small, precise adjustments to maintain alignment during sustained visual tasks. This slide introduces the concept of compartmentalization within the rectus muscles. Evidence suggests that rectus muscles are not innervated as a single uniform unit, but instead have compartmentalized innervation patterns. In the horizontal rectus muscles, distinct superior and inferior innervational zones have been identified in both primates and humans. This means different portions of the same muscle can be activated somewhat independently. Clinically, this helps explain selective patterns seen with abducens nerve injury. In some cases, the superior compartment is more affected than the inferior compartment, which can result not only in horizontal weakness, but also small associated vertical deviations. This compartmentalized control adds another layer of complexity to how eye movements are generated and how strabismus patterns can arise.
Thank you for your attention. I hope this overview helped clarify how extraocular muscle anatomy, biomechanics, and innervation translate into real surgical and clinical decision-making.